as you know, I'm part of the Association of Black Cardiologists and chair of the Women and Children's Committee. So one of the things that we've taken on is the Black Maternal Health crisis, which unfortunately in the U.S. We're not doing a great job. And for those who are wondering what exactly is the Black Maternal Health crisis, essentially is that our Black mothers are at 3 times the risk of dying from pregnancy-related complications. 80% were of a preventable cause, meaning that somewhere along the lines an intervention could have been had that would have prevented these deaths in general.
Time to embrace change and be about that life. Today, we pick back up with international pediatric cardiologist Dr. Annette Ansong as she discusses maternal fetal health issues, obesity in children, and international pediatric cardiology.
Yeah.
Talk about that.
Yeah. So I think my strength professionally has been around other women physicians like myself. You know, there are a number of Facebook groups. There's one that I belong to where it's African American women physicians. So that empowers me because, you know, we trade stories, war stories, and talk about issues that face us professionally. And then just sort of pivoting as you know, I'm part of the Association of Black Cardiologists and chair of the Women and Children's Committee. So one of the things that we've taken on is the Black Maternal Health crisis, which unfortunately in the U.S. We're not doing a great job in regards to handling it. But I will say in the last 3 years that I've been in the position, there's definitely, I think, more awareness. And for those who are wondering what exactly is the Black Maternal Health crisis, essentially is that our Black mothers are at 3 times the risk of dying from pregnancy-related complications than white women are. And a lot of the issues that surround these deaths is cardiovascular in origin. They're preventable. 80% of these deaths are preventable, and the majority being of cardiovascular origin.
So 3 times higher likelihood of dying when compared to white counterparts.
Yes.
And 80%, let me make sure I'm getting this right, are preventable.
Of those deaths are preventable. Like if you look at the CDC numbers for the number of women who died from pregnancy-related complications, 80% were of a preventable cause, meaning that somewhere along the lines an intervention could have been had that would have prevented these deaths in general.
Wow. So what? And you figure you should know this. I know the ACC came out with Jack. There was a nice state-of-the-art paper that talked about it was a mix between the social determinants of health and how that impacts maternal fetal health in that setting. It was last year, and it was riveting when you looked at some of the numbers. But a risk factor for having a complication of pregnancy, a cardiovascular, was African American race, right? Obesity and other things. So talk about some of the things, if you know, that are preventable, things that we can do, because when we talk about the I guess that maternal space, it is before you get pregnant, while you're pregnant, and then even after you're pregnant. And that's what I talk to people about when they come to see me about preconception counseling in the context of cardiovascular disease. So talk about those spaces and things that people can do, because I'm always interested, but to hear it from an expert is always really.
And I'm just a pediatric cardiologist. I stay in my lane. But what I will, when I first got into the space with ABC, I was like, what is my role exactly? I'm just a kitty heart doctor. Where do I fit in? No, but so I was like, I didn't see, I'm not an obstetrician, I'm not an adult cardiologist specialist. Like, where do I fit in? But oh my goodness, I fit in quite well, because the quote I like to say is, before Black women are Black women, they're Black girls, right?
Wow.
And
speak on it.
And if you look at the numbers for women that are, a lot of these cardiovascular risk factors are like present in women by the time they're like 20 years of age, the main culprit being hypertension. So what's happening before they turn 20 years of age? What are they eating? What's going on? And that's where I come in as a pediatric cardiologist, as a pediatric specialist. What are those things that we can do to prevent these young girls from having these risk factors, such as, obesity, diabetes, and all types of other issues that when they decide as young women that they want to become mothers will minimize the risk of them having these pregnancy related complications.
Now, when you say young girls, what age are we talking? 16, 17, 18? When do you start to, I guess, make some interventions? When should that take place?
Look, Dr. Betts, Travis, I remember.
I like that. You said, hold on, not Dr. Betts. Travis. Let me just say, I like that. Go ahead. Let's talk now.
I've seen kids, okay, as young as like 3 years old that are obese, okay, that are obese.
Now.
Yes.
Hold on now.
And I mean, for kids, so that's above the 95th percentile. You know, we use BMI, but we plot. So this is above the 95th, like obese. I mean, obesity is killing us. It's killing us. It's killing our kids. It's killing us. And you know, with obesity, it goes a whole list of other comorbidities. Because if you're obese, you're more prone to have hypertension, hyperlipidemia, sleep apnea. You know, the list goes on. And these are all risk factors for heart disease. And some of those factors I see as a pediatric cardiologist all the time.
Wow.
You know, all the time. I'm telling you. And it's scary because what does that say for our future down the road, as to how these kids are going to be when they're adults, or they decide that they want to be mothers? It's really scary. So like I was saying, you know, once I realized my role, I'm like, okay, we need to really bear down on making sure that these kids are in the best heart health shape of their lives before they reach adulthood.
Right.
So that's been my stance, is that preconception counseling. And the other thing that I've learned on this journey is that those moms that end up having preeclampsia in pregnancy, their offspring are more prone to also having hypertension in childhood and obesity later on in life. So now what I've done things a little bit differently when I take a history. When I'm seeing a child for, you know, chest pain, murmur, whatever, or high blood pressure, I'll ask the parents if they can remember. I'll ask mom, did you have any hypertension or preeclampsia when you were pregnant? So that's now part of my history taken, so that I know for this child, let me keep a closer eye on their blood pressure, because there's a risk of them developing, you know, hypertension or other risk factors for heart disease down the road.
Wow. And you mentioned that, and it made me think. So my wife, again, her background is in labor and delivery. She's a nurse.
Oh, awesome.
But now she's in our school system, right? She's a school nurse. And a lot of people say, oh, school nurse, they put Band-Aids. But we always talk, and she says, hey, I'm doing my acanthrose nigricans screening. And I'm like, well, why are you doing that? And she's like, well, you realize that diabetes, and I know what it is, right? Because I identified in my patients with polycystic ovarian syndrome and very other, other conditions. But I say, well, you're screening? Yeah, we're screening 2nd, 3rd, 4th, and 5th grade. I say, what?
Yes.
And to hear you say they're 3-year-olds that are obese, they're this, and to have her tell me about those conversations that she's having with the parent that I guess to some degree is in denial. I don't, they eat what a normal, and I'm using air quotes for those that are listening or not watching, what a normal kid eats. But, they're above that 95th percentile. Yes. They already have those underpinnings of metabolic syndrome and those type things.
Yes.
How do you, let's say you have a child that comes in with risk factors. We won't even with any of them, because we know that sedentary lifestyle, diet, not getting enough sleep are the nice mix to create those problems down the road. How do you have that conversation with the family? You see, because you let me hear this magic. Let me hear this magic. Let's go.
I don't know if it's that. And you're right. It can be very difficult, because you see like a 7-year-old obese young girl. And what I want to say to the parents is, now I know Jenny is not driving through the McDonald's drive-through by herself.
So you said you want to say that. That's what you want to say.
That's what I want to say. That's what I want to say. Okay. Let me see. Have I? No, I don't think I said it. But
it's tough.
But I tell the parent, I'm really worried about Jenny. Right now, she's already displaying risk factors for future heart disease, and if we don't change it now as a child, it's going to be really, really hard when she becomes an adult. So, as a family, because a lot of times when the kids are overweight or obese, the parents, are overweight. as
Right.
well. So I was like, as a family, I know you're working, but even taking 10 minutes out of your day to go for a walk or do something together, because I don't want to put it all on the child, because you'll see the parents, they'll look at their kids and be like, yeah, what are you eating? And blaming the child. Like,
You
I'm
know I
like,
tell you to eat fruit, but you eat Takis, or you eat this, you eat.
I know,
Yeah.
like, who's buying them? Who's bringing them home?
My,
So, and then the child is looking like, they don't want to get in trouble. But so I'm like, as a family, I try and make it a family thing. Let's try and eat better. Let's make sure we're getting our, 3 to 5 servings of fruits and vegetables, eating our high fiber meals and drinking water. So I have, it's a very heart to heart conversation. I don't come down hard, especially initially. But I do try and get it in their heads that, this is an issue and I'm worried about your child, and this is what they are going to be looking at if things aren't changed, if an intervention isn't had.
Wow. So that's a tough conversation.
It is.
And, when you think about kind of your role in that spectrum, right? From, the child born with congenital condition, whether, and you're managing that super sick patient, you see that patient grow, or you see the healthy child that comes to see you for, some benign entity, but now you look at them and they have the risk factors. And, by the time you get this patient through their pediatric stage and they end up seeing Dr. Batts, man, I got to take care of these risk factors because once they become an adult and they've developed those behaviors and they have those habits, it is hard to break on my part.
It's
right?
hard.
And I come in and I try to motivate and I try to do this. But again, it's one of those things where, how we live or what our culture is has been ingrained in us from the time we're born.
Yes.
Right? And I say, as good as I am, it is hard for me to fix you in 2 visits a year when you've had 25 years
right
to create the things you want me to fix. Right. I don't give up, but it is a challenge, right? And so I appreciate you for having that conversation at the primordial and the primary stage of prevention, right? But, at the stage where they could potentially have the disease or they have the risk factors, and then by the time they get to me, they've developed it.
I'm going to interrupt you, but I'm going to turn around on you, Travis, because you've done a lot with these kids. Actually,
okay.
I mean,
right.
I see the. I mean, you are in the fight. You have these kids running, jumping. So I mean, you are very much to be great. You're probably one of the first. I mean, adult or peds that I see actually going out there and doing something with these kids.
I appreciate it.
And it means so much. Seriously, I'm like, okay, if Bats can do it, all right, I'm in.
Okay, all right. Now that means I'm gonna sign you up. That means we're gonna put some work in. We just, and I'm glad we're having this conversation now. It's timely. Just last week, we launched a new program. It's called ECA, or Everyone Can Assist. And like I said, it was just me thinking about the Damar Hamlin situation, knowing that the integration of emergency response, people knowing CPR and grabbing the AED, you don't have to go to medical school to know those things. You don't have to be, a world-renowned pediatric cardiologist. You don't have to be, X, Y. You just have to be willing to assist. And when I talked to, I think the first group was 80 football players. The second group was a mix of football and track athletes, and to hear them, kind of talk through their concerns and to talk through not really fears, but just their apprehension about helping. And then their own concerns about their health, largely through the lens of nutrition, it was eye-opening. And I mean, and we'll have some of that content roll out, but it was just interesting to see them and to know that, there are people, such as yourself that have these conversations with kids, because I think, as much as we know and we're exposed to kind of understanding the health benefits of living well and sleeping enough, kids know too. It's just harder for them to navigate and to say, do I, stop looking at TikTok while I'm asleep or TikTok while I'm in the bed and get to sleep, or do I, grab the easy bag of chips and those type things. And so I think by you having those conversations, that really pushes that forward.
Yeah.
Now, and again, I know you got to run. This has been fun. We're going to have to do it again. But
has it been an hour already?
It's not. We can keep going. I just don't want, somebody to pull the plug. I just don't want that to happen. So now you talked about the Association of Black Cardiologists, of which I'm a member of. And like I said, and we talked about this, what are we doing? And I say we, because I'm a part of the team, this month, right? I know we have a big push for women's health. What are we doing this month so people can know, people can kind of take
Yeah.
a gander and then touch on what we're doing and then why we're doing it?
It's exciting. So, Association of Black Cardiologists is a nonprofit organization that was founded back in 1973. Actually, this is our 50th anniversary by a group of Black cardiologists, and the whole, the big mission is to minimize the disparities that exist in regards to cardiovascular disease for our community. So the Women and Children's Committee was just formed, I believe, under our last president, Dr. Michelle Albert, who's now president of the American Heart Association, the first Black woman, I believe, to be president of the American Heart Association. So I co-chair it with an adult cardiologist, Dr. Rachel Bond, who is phenomenal.
Amazing.
She is just on it. I'm trying to keep up with her.
She's gonna be on the show at the end of the month.
She's just on on it all the time. But so we did a lot our first year. We would have these table talk series. A lot of it was focused around Black maternal health, and then I had some pediatric ones in there. So last year, we launched We Are the Faces of Black Maternal Health. And from that, it was ABC members telling their stories about Black maternal health, whether it was them directly or it was another family member who had an experience,
right,
good or bad, with their maternal health. So this month, February, we are going to launch We Are the Faces of Black Maternal Health, keeping it the same, but it's going to be, you'll see different patient stories. It's going to come from the patients themselves.
Wow.
So it's going to be great. And then we also have some good educational resources for the community, different infographics that's going to talk about different ways to advocate for yourself, policies in place to sort of bring the Black maternal health crisis front and center, and what we need to do to bring it to the faces of our lawmakers, and what clinicians should be doing when speaking to moms that are pregnant.
Wow.
So really trying to empower the community. Not just but when you go into your doctor, what you should be asking, what they should be doing. Really trying to empower the community. But also bringing awareness about this crisis.
No, and I love the way that ABC still leans heavily on kind of that personal responsibility piece. And I'm not, and you'll see but we do have a responsibility as physicians to give the information, but then patients and those receiving it have a responsibility to make change. But then the other thing that ABC does that is amazing to me, the ACC does it as well, is we move into the space of public policy.
Yes.
Right? Because personal responsibility is great, but if policies are set up where you can't hit those goals, no matter how hard you try, well, then something has to change.
Yes.
Even when, let's say, there is a policy that helps to make decisions and does risk models and various things, but then the personal responsibility of the folks administering the care isn't moved in that space, isn't done. And so I love the way that we marry the public policy and personal responsibility through the lens of individuals such as yourself, who are experts that have seen it from, birth, that have seen it from, the pregnancy and knowing how to articulate risk in that. And so I applaud you all. And I'm just always amazed at the work that the ABC does. Now, you mentioned the Association of Black Cardiologists. Let's be clear. You don't have to be African American to join.
Thank you.
We have tons of different levels to join. Whether you're a community organizer, whether you're an internal medicine, you don't even have to be a cardiologist. You don't even have to be a physician. So because I know you do a lot of programs with the ABC and your sorority. Do you all have anything planned? Maybe not ABC and your sorority, but I know Delta Sigma Theta is very active in Heart Health Month. And so anything that you're doing in the DC area or even you may be traveling and doing it. I don't know.
Nothing that I know of yet on a national level, but I will find. But trust me, if I see it, I will post it.
All right.
Because I know something. I'm sure something is in the works. I just haven't kept up with it all yet. But Deltas won't let you down.
Yeah, they never do. That's what again. That's why I'm always looking. I say something's gonna come out. Something's gonna float, and I'm gonna see it, and y'all gonna do great. Now,
Yeah.
and we didn't touch on this. Like I said, I'm trying to hit all of it because I don't. You're so busy. I don't know when I'm gonna get you back. So I'm on. So let's talk about the other hat you wear, right? And that is kind of your approach to kind of the world needs in the space of cardiology, right? You
Oh,
mentioned
wow.
you see
Yeah.
where I'm going, and
Yeah.
it's one of those things where we think locally, we manage
Yes.
policy nationally, but there's risk internationally. And
Oh,
I
yeah.
know the ABC has a program like that, the ACC, but you started it. You said, I'm going to do it on my own, and then you partner. Talk about that international advocacy piece
Yeah.
that you've been able to do, still managing in practice, still being a mom, still being a wife, still doing all those
Yeah.
things. How do you do that? And what
Yeah.
is it?
I knew once I got into medicine. That's what I love about medicine is that you can take your skill set anywhere. That
Mm-hmm.
I was going to do something in Ghana, something international. Like I said, to whom much is given, much is expected. So when I couldn't do that in residency or fellowship. So when I became an attending, an opportunity came to do some work in Haiti. There was a group, actually at the institution that I'm in now, but I wasn't part of it then, where one of the Pediatric Cardiologists was going to Haiti every year and just screening kids for heart disease or kids who were already known to have like rheumatic heart disease and other
Wow.
congenital lesions. And we were just seeing them in this, our makeshift clinic doing echoes. And what was so sad about the situation in Haiti in particular is that there's no pediatric cardiologist there, and they don't do heart surgery there unless they're fly-in missions. So a lot
Wow.
of times it was similar to God, you're making these diagnoses, but there's not much you can do. And I remember very vividly, I think it was my last trip there before the pandemic. I'd gone there like 3 or 4 years in a row. My last trip there was a 4-year-old girl with a VSD, so which
Mm.
stands for ventricular septal defect. It's a hole between the bottom chambers of the heart. Here would have been repaired in in an infant. It would have been diagnosed as a child and would have been repaired before the kid hit 1 year old. This girl was 4 years old, and because she had the VSD for so long, her lungs were damaged. Okay,
Oh man.
and she had something called pulmonary hypertension, and that's when the pressures in the lungs are really high. And it comes to a point where no medication or intervention can reverse that. So she had Eisenmenger's, Travis, and because of that, couldn't really have surgery. So she was, she was blue. She was very,
And
yeah,
explain Isaac, because I know
yeah,
it's medical speak, and I'm seeing it
yeah,
in my heart. I know that prognosis is terrible.
yeah,
Explain Eisenmenger's physiology and that reversal of flow phenomenon. Just
yeah.
in I won't say layman's, but as simply as you
Typical,
can.
yeah.
Folks. Yes.
Yeah, so you have the hole in the bottom chambers of your heart. So that, like I said earlier, the two bottom chambers are the pumping chambers in the heart. But the left pumping chamber, left ventricle, has the higher pressure. So if there's a hole in the heart, the blood is going to go from the left to right, from the left
Hmm.
ventricle to the right. And when it goes to the right side, it goes immediately to the lungs. Okay. And over time in babies and little ones, and this is how we know something may not be right, is that extra blood flow going to lungs is going to cause the baby to breathe fast. And when they breathe fast, babies don't eat well. And for them, eating is their exercise. So when they do eat,
Wow.
they may even sweat a little bit because that's babies just lay there and they eat. So eating is their
Hmm.
exercise. And so over and over again, this blood just recirculating. It's sort of damaging the lungs. It's because the lungs aren't supposed to see high pressure. So when you have a big defect, it's just seeing all this high pressure. And if something's not done about it, like within a couple of years of life, then what happens is that shunt, it's going left to right. The pressures in the lungs become so high, the blood is going to start shifting right to left. And
Mm.
at certain points, you may be able to treat it, like give medication that'll lower the blood pressure, lower the pressure in the lungs, and cause it to go more left to right. Maybe some interventions you can do, but if nothing is done about it for a few years, then you get something called Eisenmenger's, where the pulmonary hypertension, and that's what it's called, is so bad it cannot be reversed. And the blood is then going right to left. And blood that's on the right side is blue blood already. So what you may see in someone who has Eisenmenger's is that they're going to look blue.
Mm.
They're going to look more blue than pink. They're going to look, because all that blue blood is now going to the left side of the heart. And when
Wow.
it's like that, it makes it difficult. You can't do a repair because usually a VSD repair, and this is what I was getting to with this young girl. It's a very, I'm not a surgeon, but it's one of the simplest cardiac surgeries where you just, you patch it, and that you're one and done. In a lot of these countries like Haiti, it's the type of surgery is just one and done. But because they don't have the resources there, these kids live with holes in their hearts and develop Eisenmingers, and they end up dying, from something that could be easily repaired. Here in the U.S. or some of the other countries with resources. So it's sad because here we are in 2023 and we still have kids dying, from VSDs or a PDA even. Patent ductus, things that could be easily repaired. Easily repaired. And it was a similar experience in Ghana. So anyway, so that young lady, she passed away right in front of me, literally. She was blue. She was in and out of the clinic there, and we tried it anyway. And so it was just sad to see that. And then I spent time in Haiti. Then I went to Ghana, finally. There's a surgeon at Boston Children's Hospital, Dr. Francis Fenn Thompson, who's been going to Ghana, so I think close to 20 years now, or for a while. So I was fortunate that I was able to meet up with him and got invited to go on a trip with them to Ghana. And that was nice because that's where my parents are from. And so same thing where we were screening kids. And, these people find out about the trip ahead of time. And so they'll line up in the clinics knowing that the group is coming, hoping to be seen and be one of the people chosen to have surgery. And it's sad because, you can't help everybody. And you want to do those cases that aren't going to have a lot of complications after you leave, right? So yeah, in some cases we had to tell families, hey, sorry about your child, but we can't, this is you can't do anything for them, and so, and then they're begging, and that was rough. And you only hope that when you return next year they're still alive. So it was tough, but turn that around, there were the kids that we were able to help to screen and actually do surgery for while we were there. So my big hope is, in Ghana is a country of 30 million people, and they have one pediatric cardiologist, Dr. Yao, who is seeing any and everything coming through. So she's a busy woman, and I'm really good friends with her and touch base with her, and it's busy. Her hope is that the government will help support the training of other pediatric cardiologists there. They have a big medical center there, so she's hoping she can find space there to open up a clinic and see more kids, get equipment. But like anything, if the government doesn't make it a priority, and that's the universal theme, I think, in these low to middle income countries, if the government doesn't make it a priority and put the money and resources in, it's very, very difficult to help these kids to make it happen. You have to have some government backing, or private, if they're private businesses that can help, but those are few and far between.
So an amazing story. I'm just imagining that line, right? Just thinking of folks standing outside, maybe camping out. When we think of people camping out, I went to the University of Kansas for basketball, and there'll be people. You went to Duke, so I know you understand. And it's a different environment with people waiting days and just knowing in anticipation that you all are going to be there, and just setting up camp in the hope that they can kind of cross your face and something about them says, yep, this person's good to go, and making those decisions. Just and I guess when I think about it, how many patients did you see in a day, and how did you have that resilience to know that you're going to probably have to say no more than you say yes, right? And knowing that this could be fixed, we just don't have the time or the resources to follow you up. How did you get that resiliency, and what did the day look like for you in that international space? Yeah.
So when in Haiti, this wasn't for surgery. We weren't screening kids for surgery. We were, but not during those trips. We were checking, but in Ghana, we were there for 9 days total. So getting there, setting up, and then the first 3 days is screening kids. So maybe about 15 or 20 came through the clinic, and then we had to select a certain number, it might have been 10 kids for surgery. So then from days 3 through 9, you're doing the surgeon, Dr. Fenn Thompson, was doing 2 cases a day. So probably around 8 to 10 cases, out of the maybe close to 40 to 50 kids that you're seeing. So they were busy. We were busy. And like I said, it's certainly sad when those kids that you can't really help are, you have to turn them away.
Turn them away.
Yeah.
Wow.
And this was my first trip there, but some of the members that I was working with, they recognized some faces because these are the families that kept coming, hoping that this would be it. This would be the time for their kid to have surgery, and again they were turned away because it was their heart disease had just progressed. And
right.
You would do more damage or harm by going
right, having that follow up and that
exactly
line of care in that space.
Exactly.
Man, now what's next? What's next on the international horizon? I'm curious.
So life has been busy here domestically.
So before we go travel, hold on, let me settle stuff down here.
Yeah, and then the pandemic, of course. But no, my ultimate goal in life is to go back to Ghana, and I really want it to have a center of excellence. I think Ghana is unique in that they have a very stable democracy. And are very accepting of others, coming there and even becoming Ghanaian citizens. And I think the healthcare should be no different, where I think Ghana is one of the few countries, or maybe the only country in West Africa that even has a cardiac center. So they have a cardiac center, and they actually have a few of the cardiac surgeons trained in pediatric cardiac surgery. But a lot of it, again, is still, but you need support, right? You still need someone who knows how to do anesthesia, who's comfortable doing surgery on kids less than 10 kilos. But my hope is that at some point, Ghana will be able to do that. They'll be able to accommodate, the little babies. They don't do, rarely do any neonatal cases. They have to be referred out. I think Dr. Yada sent one child to India, and some come to the U.S. But where they'll be able to do it all in-house. Getting to that point, though, like I said, will require the support of the government or, perhaps one of these private foundations. You just never know. But I want it to be a center of excellence for West Africa, if not all of Africa.
Wow. Well, again, with somebody like you championing those causes, making those trips, talking about the benefits of Ghana and what they already have set up for infrastructure, I don't think it's too long. I mean, I don't know. I might be calling you ambassador and doctor. I don't know. I might be saying both, So
from your lips to God's ears.
There you go. That's what we're hoping. But you did, and then like I said, it's just I got you. So I just want to keep asking questions. I promise I'm gonna stop at some point. Talk about the pandemic internationally, and then bring it back home, right? Because I know you've done some research. I think you had an article last year that highlighted kind of vaccine-related myocarditis cases in adolescents and its prevalence. But just and you can talk about your research, but more broadly talk about kind of what you've seen or heard in the international space with COVID in kids or COVID in children, and then talk about here in the United States and what that looks like.
Well, it's interesting. Like, if I think about Ghana, like, so how's COVID? They're like, oh, we don't see it a lot, but but the question is, excuse me, how often are they testing? Not that it's not there, is how often is it, being tested there? But I remember when the pandemic first started, it didn't seem to hit Africa as hard as it was here in the United States. And then I think it did, but I didn't get the same sense of urgency there as it was here. So again, I think a lot of it just has to do with how things were testing. And unfortunately, I have to say at least I didn't hear of any of my extended family members coming down with COVID. So who knows? And then so that's that. And they were able to get access later on, I think, in Ghana to the vaccines. And I'm not sure where things stand now in regards to boosters and things like that there. But it just didn't seem as big. I'm sure, but it just didn't, as it was here.
And that was the same thing that we saw. I was in Afghanistan, and we knew it, but it just didn't kind of hit the same notes that it did here. And I guess looping back to now, what did you see in your practice here, right? Because I deal with adults, and we were on high alert, and we shut down, and we went virtual, which I think had pluses and minuses. I mean, I like the fact that now we're able to have more access, but I do feel like there's some connectivity challenges that exist, for more of our mature patients. But what did you see in the space of COVID as a pediatric cardiologist, and then vaccine? Hold on, real quick. Let me just. What did you see in the space of COVID for your pediatric population, and then those discussions with parents about the vaccine? What did that look? Okay, so you already, oh brother, I don't even. You gotta tell me. That's what. And after that, that's what I've been waiting this whole talk. I said I gotta ask about COVID and kids and I gotta ask her.
No, the biggest thing I think was like you alluded to, was the vaccine-related myopericarditis, where especially in the young teenage boys who had gotten the vaccine were presenting with chest pain, shortness of breath, and palpitations. And, the CDC was looking heavily into that as to, was there a causal relationship between that? And I think what came out of it was that they couldn't directly pinpoint it, but there seemed to be a close association. So and there's a big but, was that it was transient. This wasn't like the myocarditis that we know of, where kids are really, really sick and in the ICU on drips and all that. We didn't see any of that. What I was seeing was, symptoms of chest pain, shortness of breath, and palpitations. You check out your troponin and it's elevated. And then by and large, you admit, just to be cautious, we were admitting these kids, but they'd be there for a couple of days. You send them home with anti-inflammatory agents. They follow up in clinic and they were fine. And that was the extent. I never saw, in my experience, anyone who got really sick from the COVID-related myopericarditis. Admitted to the ICU. I did not.
From the vaccine, or because I know for us,
this is from the vaccine.
Okay. Yeah, because there is, and it's similar, right? There's a difference. Even the CDC highlights that, okay, let's just say there is, and they agree, there is a signal, right? We saw it in kind of that large study of Israeli military members. We saw it to some degree in the Big Ten consortium. Yes, we see it, but the sequelae or complications from vaccine-associated myopericarditis versus you getting myopericarditis from the virus is much different. And I didn't know if that, kind of transcended the pediatric population, which you're saying, it did, because your research, again, looked at it. Talk about, that piece, right? That research piece that you said, hey, COVID related in kids, what do we see, or what does that look like? And I think it echoes what you said.
Yeah. I mean, it was that, yes, we do see that perhaps there's a relationship to, the COVID-19 vaccine. There could possibly be a transient myopericarditis from the COVID-19 vaccine, but the risk of not getting the vaccine and getting a myocarditis is much higher, much riskier than is much riskier because you could acquire the COVID-19 virus and get and get the myocarditis from it. So that was the essential, because we didn't want people to have a reason to not get the vaccine.
Right.
And wanted it to be understood that this is a possibility, but it's not worth sitting around and not getting the vaccine. Exactly. And I think, after a while, we heard it like the first, I remember it was when I started it was like all of the summer of 2021. Mm-hmm. Then in the fall, I haven't really heard too much about it anymore. Not saying that it doesn't occur, right. But certainly not to the extent that would, make us stop giving the vaccine. And as we see, because we're now off with our mask, that the vaccine has its benefits. But it's funny because you mentioned some stories, and I remember I was out in one of my clinics one day, and I was asking patients, have you had the vaccine? And I remember one family said no, and then I said, why not? And she's like, because it turns you into zombies. I was like, come again? And I was like, they're like, no, it turns you, and they were dead serious, Travis. Dead serious. Like, because I was about to say like, oh no, they're serious that the vaccine is going to turn them into zombies. But these were the beliefs that they had. Some people still have, probably, about what the vaccine could possibly do to them. And that was scary. That this misinformation that gets
There you go.
circulated over and over. People believe that. They really believe that.
Yeah. So, yeah, and I think that's the challenge, and you've done a good job, I'm sure, with both your patients and their family to dispel that myth, in the hopes to say, hey,
Yeah.
look, that are there, some concerns, sure, and we'll highlight those, but the benefit far, far outweighs the
Outweighs,
risk.
yes. Yes.
Well, it's been great. I love it, and I still got more. So you're gonna have to come back. And I always say that at the end, not to everybody, but you're gonna have to come back. That's a wrap. We gonna have another discussion. But if you had a couple of key take home, pieces, right? So we talked about a lot, right?
Hmm.
So what would you tell kids to be healthy and whatever you want, kids, we can
Yeah.
talk about kind of that maternal fetal piece, and then anything else, right, that you want to, encourage. Just what things would you say kind of as your key take home points
Yeah.
for this discussion? Because we're going to have you back. So, that's already going to happen. But what would be some key
Yeah.
things you
If
would
I'm
take
talking
away?
if I'm talking to the kids, I'd be like, don't let anyone tell you you can't do something. There were many points in my life where I could have just stopped or not felt that I was worthy to, pursue medicine. But I knew within myself, you just got to believe like I could do it. This is something that I want to do, something I wanted to pursue,
Wow.
and I wasn't taking no for an answer. So if you really believe that you're meant to be somewhere, meant to do something, don't let no be your answer. From anybody.
Love it.
People don't know you. No one knows you better than you.
Mm-hmm.
Okay, maybe your mama, but no one knows. But even then, something no one knows you better than you, and no one knows what you are capable of. So don't let an outsider come in there and tell you what you can and cannot do.
Right.
Period. You just have to know yourself and be true to yourself at all times. And the other thing I'd say, show up, and later on in life, show out.
Mm-hmm.
Show up, be present, be engaged, be involved. Even if you have nothing to say, just show up. Take it all in, listen, and then show out. Where
Wow.
not don't be afraid to express yourself. And this is something that in medicine we're very siloed, and sort of it's a conservative kind of a
Mm-hmm.
field where you can't really show you can't be on social media or
No.
self promote yourself. But then I learned later in life, you kind of you kind of have to. I mean, because
Yep.
people aren't going to know what you're doing unless you say something about it. You're going to
Exactly.
be, and you see other folks doing it, and then you have folks who don't even have the right information out there saying stuff. Where we're
Yep.
trained, we've had decades of training, and we're
Mm-hmm.
trying to stay in our shell. Nah, show out, show up, and show
Show up
out.
and show out.
Yes, show out. So don't be afraid to express yourself in a positive way so people know who you are and what you're about and what you can bring to the table.
Well, I love it. Well, where can people find you so they can see you show up and show out and encourage them to show out? Where can they
Right?
find you? Where can they see you? Again, one of the top pediatric
Stop,
cardiologists in the
Travis.
country.
Travis,
I'm not.
stop.
I'm okay. Google don't lie. First, you know how back in the day we used to look at Jet. Like if you ain't believe, look at Jet. It's in Jet. If it was in Jet, it was true. I
This is
bet
true.
they got you in Jet. Is all I'm saying. I don't know Jet and Ebony. They got them in both. So show up, show out. Where can they see you, find you if they want to reach you? Because I'm sure people are gonna
Yeah.
want more of this information that you're giving.
Sure. So my Twitter handle is at Kitty Hearts, KIDDIEHEARTS, and then LinkedIn under my name, Annette Ansong, and then I'm also on Facebook under my name, Annette Ansong. I think I'm on Instagram. I think it's Doctor Annette, at Doctor Annette too as well. I don't know how to do TikTok and some of these other things y'all do. It's too much. So so those are the four basic ones.
Hey, that's a way for people to reach out and get some of this information. Like I said, it's been great. First off, thank you. You enlightened me. I know I told you only, and I couldn't, I had to ask more questions. I had my show notes and I'm going through them. I was doing all right until you start breaking it down. And I'm like, okay, now I'm gonna turn to student. I always like when the interview turned into class and I'm taking notes and you seeing me writing and I'm taking screenshots of it. I'm like, But no, but you're a wonderful person. I truly
Thank you.
love your energy. I love your passion. And like you said, I mean, people such as yourself, I'm glad you're not quiet, right? Because medicine needs you. They need your voice. They need what you do for people. Not only the medical side, but the humanistic side, right? That your ultimate goal, and you said this, you said your ultimate goal is to go back and change the healthcare system of an entire country. And then you said, forget the country, I'm changing the west side of a continent.
Yes.
I mean, do you realize the power in that?
Yes.
And what I can tell you is that you just got a new team member.
Oh, thank you.
One thing I've learned, right, as I've done this and met some of the best people, through this discussion or through these discussions, has been that if your dream or your vision is easy enough for you to do it by yourself,
Yes.
it's too small.
That's right.
It's too small,
That's
right?
right.
And so, whatever I can do, I know I'm an adult cardiologist that focuses on prevention and sports, and I do a lot. Whatever I can do to help propel what you're doing to change a continent, to change the world, sign me up. Sign me up.
All right, Dr. Betts. I got you.
I'm saying it.
I know.
I'm real.
You're
know I'm
military.
real with
You're a military man,
mine.
so I know.
I'm real with mine. But thank you again, and as always, you all know this is the About That Life podcast with Dr. Betts, the Lifestyle MD, the podcast that focuses on life or living intentionally forever. Again, today we were blessed with intellect, with energy, with passion that all tells you all that you can do it. You can live that dream, even coming from humble beginnings and seeing what, goal setting and not stopping. And biggest thing is not taking no for an answer. So if you want to embrace what you want, espouse those behaviors that we heard today, and you certainly can be about that life. Thank you. Hey, this is Dr. Betts. If you enjoyed anything about what you heard, give us a 5-star review. If you want to hear different content or have other questions, let us know on all platforms so we can help you live intentionally forever.